Hey guys, today we're going to go through the palpation of the GH joint. The GH joint has a lot of palpations. It's an extremely mobile joint. And so the palps that we're going to do are long axis distraction, A to P, P to A, compression with circumduction, decompression with circumduction, internal and external rotation, S to I in flexion, S to I in abduction, and then I to S. The first palp then is long axis distraction. Long axis distraction looks very similar to the I to S palpation of the AC joint. But what we're doing here, you see that I've got my patient's arm between my knees here. I'm going to use my inside hand and I'm going to put it in her axilla, so kind of up in her armpit. And what I'm doing is I'm taking my contact with the scapula and I'm pushing and holding the scapula. What I'm going to do is try to keep the scapula stationary and distract the humerus away from it. So as I push here, I'm then going to take my outside hand and I'm palpating over the top of that GH joint, and then I distract with my legs. And I should feel that humeral head move out of that glenoid fossa. Okay? So a quick recap, I put my hand in here like that, and then I'll palpate over top, and then just distract. Next is an A to P palpation. Again, I'm going to keep my patient's arm here between my knees. I'm going to palpate the scapula here. So I'm letting my hand roll under, and I'm grabbing that scapula here. My other hand is coming on top to press straight down on the humeral head. So again, wrapping around, palpating over the top on that humeral head and pushing straight down. If I want to do P to A, I can take this hand contact that I just used and I can roll it up here now. And now I'm going to apply pressure straight down here with my hand. Now, be careful because we're sitting on a clavicle, and so I don't want to put a ton of pressure straight on that bone, just like we did during our palps before. We don't want to push real hard on that clavicle; it's painful. Nor do we want to press on that coracoid process. So we're adding a little bit of pressure here. I'm spreading it out over the entirety of my hand, and then I'm going to pull that humeral head up. So a P to A palpation here. So it looks like here, underneath that humeral head, and then pulling it straight up. All right, next on our list is decompression with circumduction. So with decompression with circumduction, we've got our inside hand. We're going to come up in our patient's axilla here, and we're going to take the outside hand and then put it down here closer to the elbow. I'm going to use my inside hand and decompress that joint, stressing that joint capsule. And then I'm going to use circumduction to kind of explore that joint capsule here and see if my patient's symptomatic here. Okay, so again, up in that elbow, decompress. Sorry, up in that armpit and then decompress. And then we'll do some circumduction there to explore the joint capsule that exists there. Next then is compression with circumduction. So I'm going to flip-flop my hands. If I was here before, now I'm going to rotate it and go this way. My inside hand's down by my patient's elbow, outside hand's out here on the shoulder. I'm still using my legs to help stabilize that distal upper extremity here. I'm going to compress the humeral head into the glenoid fossa, and then I'm going to do circumduction again. Here I'm going to be stressing things like the labrum, the articular surfaces of this joint. So this is an important palpation to see if that's making my patient symptomatic. So again, I'm going to compress out here and then circumduct. Next is internal and external rotation of the shoulder. So we'll start with external rotation here. For external rotation, I'm just going to bring my patient out here kind of in that scapular plane, which would mean that we're out just not straight at 90 degrees here, but just at a little bit of a deviation where that scapula comes around, that glenoid fossa is in a position then that humeral head can articulate well with it. And I'll allow for external rotation here, looking for about 90 degrees, and she's got that for sure. and then internal rotation, which is here, and I need about 60 degrees of internal rotation. Definitely don't have that here, so we have a little bit of a restriction in that internal rotation. Next, we're going to do STI palpations. We do two different ones. We do one in flexion and one in abduction. The one that we do in flexion, we start by bringing my patient's arm up like this, and then I'm going to bring that shoulder up like that. So she's nice and flexed at the shoulder here. Take your patient's arm, bring it out to the side, establish a contact along the inside of that arm here, and then a contact on the outside of that arm here. Your shoulder is going to come down and contact your patient's elbow. So as I do that, my shoulder comes down here. I'm going to take some of that slack out and then challenge. Okay. The next palpation then is an STI and abduction. So if I'm going to do an STI palpation and abduction, taking my patient's arm, I'm going to palpate that humeral head here, and then as I bring that arm out, I'm going to use that natural S to I motion that should exist when I abduct that arm, and follow that motion and challenge it as I go through. So here's that palpation here. I've got an index on that humeral head. I'm going to guide her arm into abduction and then challenge straight down as I get it to about 80 to 90 degrees of abduction. Okay? The last palpation that we're going to do is an I to S palpation. There's two different ways that we can do an I to S palpation. The first way is I'm going to cup her elbow, allow her elbow to flex, and then I'm going to take my hand contact, the back of my hand, and I'm going to put my knee against it. My outside hand, I'm going to come up and over the top, and I'm going to find the scapula here, and I'm going to compress. I'm going to compress S to I on that scapula, and then I'm going to use my knee and hand to push up on that humerus to challenge inferior to superior. So I to S here. So that looks like this, and then compress up. That can be a little bit of a challenging palpation. It does require a little bit of upper body strength, and you need to be able to compress that joint, but then also soften your hands just enough to feel the rebound that that joint produces. So another way that we can do an I to S, if you don't feel comfortable there, is to bring my patient's arm to about 80 to 90 degrees out. And then I'm going to take the slack. Look at all the slack that exists here. Remember, it's an extremely mobile joint. See how much slack exists here? Here's where her shoulder was before. Here's where I'm going to put it at. And then I challenge with a little bit of over pressure. Okay. So this was the palpation of the GH joint.